This is something you may see, and just so you can see the differences. Now the normal, this is what a lot of people see, is the anterior wall placement of the electrodes. And you'll see them place that. You will see a lot of the EP doctors do is you're going to see a front to back placement. And their theory is that they'll actually feel, if you can look at the way this drawing is right here, is it gets direct conduction to the heart. And they feel it gets better. They feel that it doesn't get as good conduction through. Now, we can have electrical cardioversion or chemical cardioversion. Chemical cardioversion can be, an example would be using amiodarone. And you also see as some EP doctors will do is they will actually, and I don't recommend this, it's just giving you information, is they'll put pads, they'll put towels on the chest, and while they're shocking, they feel that when they're putting direct pressure down it creates a better, the shock goes deeper and a better chance for cardioversion at that time. I don't recommend doing it. You'll see some videos of people doing that. You can have risk to someone who's doing that. That's something that discussion in your provider realm if that's something that you want to do. I'm just giving you information that if you do see it so you understand why they're doing it and why they're doing that. Now make sure they're not standing in a puddle of water when they're doing that. But usually you'll see them put towels on there and they're putting pressure in. They feel it's better for people who are obese. So that helps direct the current directly towards the heart. All right, let's come with a clinical scenario. We did a multiple choice question. Let's talk clinical. So rapid response was called. Now, I want you to think about rapid responses when these occur in your facilities. These are escalations of care. And these are sentinel events. And you may work at a facility where there's a lot of rapid responses, where a family member can call a rapid response. A rapid response is called when someone stubs their toe. But these are a legal event. I want you to think of these as a sentinel event. And in your career, I will tell you bad things will happen if you avoid sentinel events. So meaning that someone has asked for help, and it's almost like someone is asking you for help and you say, no, I'm not going to help you. So if you go to a rapid response and you kind of blow off that rapid response, even though it may not seem like a big thing, something has occurred where medically legal that you need to start thinking of, and also for patient care, is something needs to happen for this patient. A higher level of care needs to happen. So let's go back to this question again, or this clinical vignette. A rapid response was called for a 62-year-old with an unknown past medical history who was inpatient for sepsis, okay? So, and this is one of those patients, the typical patient that, thinks that everything's a conspiracy theory. You go in there in the room and he's a guy who smokes that says that he doesn't think that smoking is bad for you because he saw a video on TikTok that says it's good for you. You go in a room and he's tripoding like this, okay? Now, what's this important thing that is going on? We said inpatient for sepsis, right? Inpatient for sepsis. Now, what happens to patients who get sepsis? Unfortunately or fortunately, what happens? What do they get? Well, they get shocked, yeah. How about the intervention? Do they happen to get a lot of fluids? Yeah. Do they sometimes get fluids in people who shouldn't get fluids? Maybe. So what happens is, again, the 30 milliliters per kilogram, and we'll discuss this later, but there's no evidence for that. I don't care where you look, there's no evidence for it. It was literally a group of people were sitting around and go, we need to get fluids for sepsis, because people weren't getting fluids. And they literally said, hey, let's give 20, let's give 40, let's do 30, guys, let's do 30. So we're stuck with that, but there's no evidence for it. I guarantee you will not find a study on it, because you can literally, it took me years to figure it out. It was a podcast of one of the original people that kind of came up with the sepsis criteria, and someone asked them. And it was basically a discussion. So we're using false data that's required to us by the government to go ahead and give these patients fluids, and sometimes it can be too much for these patients. So you're coming into the room, a rapid response was called. This is a patient who has an unknown medical history, and they know they smoke, and they think that smoking is good for them. They receive fluids for sepsis. They had their sepsis coming in, they got their fluids, and then from when they got the fluids is they went up to the wards. And then you go in a room and they're doing this. Okay, you look at the monitor and you see their heart rate's 122, the blood pressure's 210 over 100. Respiratory rate, he's probably in the 40s, and his SpO2 is 90% on 15 liters non-rebreather. All right, so what is he in? He's in respiratory failure. So what's the definition of respiratory failure? And so if we have the SpO2 less than 60 milliliters, or the peripheral oxygen saturation is less than 91%, if no ABG is available. So a lot of times as you're going in a room, you're not going to have time to get an ABG. Maybe your ABG machine, your point of care system isn't working. You need to have 2 or 3 to get these criteria. So first is, we're going to say is oxygen saturation is less than 91%. The PCO2 greater than 50, okay, so you get that unless you have a special invasive monitor that you can get that, or non-invasive monitor you can get that, you're going to have to get a blood gas with a pH less than 7.35. Okay, this means it's acute. So you have an elevated PCO2 and you have a pH less than 7.35. And you have respiratory distress. We talked about what are signs of respiratory distress. Using intercostal muscles to breathe, rapid breathing, work of breathing. Those are signs of respiratory distress. So when you're examining a patient, I want you to get in the habit when you feel that they're in respiratory distress, is I want you to look to the side. If you look to the side, you see a lot better, especially in someone who's, we'll call them an Oklahoma medium, okay, where they have a little bit extra carrying on, okay. It's harder to see this area because they may not have a neck. They may have a neckless Oklahoma medium where you can't really see if there's anything going on here because there's nothing to see because there's no neck. So go to the side. Even if they don't have a neck, they'll have a little gap in there. In that gap, you can look and see, are they working to do this breathing? Are they having to push? Are they in distress for that? So what's going on? So let's go over here. Let's look at, this is a normal chest x-ray, okay? This is a normal chest x-ray. And when you're looking at a chest x-ray, first thing you want to kind of do, and this is a quick little thing, is I want to walk the outside of this chest x-ray right here. I want to look right here. What am I looking for? I'm looking for a pneumothorax right here. Look at my beautiful drawing right here. Look at that no pneumothorax right here. Now I cut off here the radiation tech. They cut that off. I shouldn't do that, but right here, look right here. Okay, so we're looking for pneumothorax. One of those things. Now we're starting to look. Okay, we're looking to see, is there a bunch of fluid in there? No, there's really not that much fluid on here. This shadows right here is, this is a female. This is from the breast. This is shadows from the breast right here. Okay, so this is what we're looking at. This. You have to get fast at these because if you go to this rapid response, things are going to be going on quickly. You need to get everything together quickly. You need to figure out what's going on with the patient, so you need your diagnosis and then your treatment. This patient, as we can all agree, is not doing well, okay? They're at risk of death, okay? So this is where, so that's a normal chest x-ray. Now this is what that patient's chest x-ray is. Okay, so what's going on? This is actually a patient that was presented and received fluids under the correct, from the suggested guidelines of having 30 milliliters per kilogram of fluids. This is exactly what they received to the dot, and this is what happened to them, okay? They came in for, I believe this patient had cellulitis, and then they got those beautiful fluids. So look right here. So what are things that we can see? Now, we have more fluids here towards the head, and the fancy word is cephalization. This is cephala, your head, cephalization, fluids towards the head, as simple as that, right? You have an increase. Now, there is an increased cardiothoracic ratio, meaning that if we measure the total width of the thoracic region and we measure the heart, it's greater than 0.5, okay, which is consistent with enlargement of heart. Now, I want to give you a warning on this. This is done as what? This is a portable film, okay? In a portable film, the tech can do lots of things in manipulation, just how far they're putting the machine, how close they're putting it to the patient, where it can give this ratio. So on a portable film, it's not great. Now, if you're in a PA and lateral, you're standing and it's a set point and those are set parameters, it's much easier to determine if someone is having, if the heart, an increased cardiothoracic ratio. But this, you can definitely agree, is this guy's got a big heart, okay? The heart is very large for the cavity of his body. This is another thing, and you really, it's hard to see these, but these are right here is called curly B lines. These are short parallel lines to the lung periphery. And you can kind of see, this is, just imagine, this is fluid coming from the periphery, from the sides of the lung, going inside the lung. Do we like fluid in our lungs? No, we want dry lungs, okay? We want dry lungs. So what's something in our lungs? What happens when we have fluid in our lungs? We get a cough, right? Because our JA receptor in our lungs, what happens? It gets irritated, it doesn't like it. Our body is designed that. It says, I don't want fluid in my lungs, because when you get fluid in your lungs, what happens? You don't breathe well, right? You don't breathe well, and we'll talk about this. And this other thing is you have this bat wing, okay? You have this bat wing appearance right here. See this kind of bat wing in my beautiful drawing right here? See this? This is a bat wing. Can you see that? All right. Or butterfly pulmonary opacities if people want to be fancy, okay? All right, so what happens? So we're looking at the alveoli level. This is the balloons inside the heart, the little balloons. And look at these. All right, this is normal. Look, no fluid in there. Okay, look at this. You're able to get fluid in and out. So you're able to get fluid in and out of these lungs. Okay, you're able to have oxygen come in and you have CO2 come out. Oxygen come in, CO2 come out. Now you can see on this one right here, there's some congestion right here. Okay. Now you have to realize this, that fluid gets in there is you're not going to be able to do your gas exchange, not going to be as well. So you have fluid in there, your gas exchange. So you're not going to have, your oxygen is not going to come in, and your CO2 is not going to come out as well. Just like that patient we talked about, okay? The oxygen's not going to be able to come in, so he's hypoxic, and his CO2 is elevated because we have a barrier. Now this is what if we went into his alveoli and we could cut him out, this is what his look like. See that right there? Just see how simple that is? That fluid increases hydrostatic pressure forces into the alveoli. So that fluid gets forced into the alveoli. Our little balloons at the end, are they going to be able to carry out gas exchange? No, there's just no way. There's no way it can. So what is a treatment you can do? What is an acute treatment you can do? Escape. Now, you'll see this. There used to be a lot of videos on this on different online platforms. The reason why you don't see them as much anymore is because they showed people's faces and they got taken down because of that. You'll still see some here and there, and there are certain websites where you can see this. So it's sympathetic crashing acute pulmonary edema. Sympathetic crashing acute pulmonary edema. So we're having a sympathetic response. Remember his pressures were high? Why is that? Why is that? His pressures were high because his body is locked down. You have vasoconstriction. You're saying, why do you have vasoconstriction? The pressures are high. So let's talk about what we have. A rapid onset of acute hypoxic respiratory failure, hypertension, diffuse crackles. That's our guy, right? He's hypertensive, respiratory failure. Remember, he's doing this. Remember, we looked on the side and we saw he's doing this right here. And he has, if we happen to have one of those things called a stethoscope, I know most people have those anymore, but you put that on the chest. You put it on the chest and you hear crackles. And we'll talk more about crackles, but it sounds like snap, crackle, and pop, okay? I know people don't have those anymore, but maybe consider bringing it to the room, just as a favor. And what's the janitor going to tell you? The janitor that is cleaning the first floor, and you're up on the 8th floor, will tell you give him IV furosemide, right? That's the treatment, right? The janitor can tell you that. So let's be a little bit better than the janitor. Even though the janitors are very important, let's be better than the janitor. So what do we have? We're a sympathetic activation. The body is in stress. So we have vasoconstriction, shifting blood to the splanchnics to the lungs. The splanchnic constriction in the system of the blood vessels supplies the abdominal organs. Those are our splanchnics. Wherever your splanchnics, you think of our abdomen right there. The organs for the stomach, the liver, the spleen, pancreas, small intestine, and large intestine. The BP is increased because what happens is you have constriction of these splanchnics, right? So our kidneys, remember those macula densa in the kidneys? You learn all the stupid stuff so you can put all the stuff together. The macula densa in the kidneys, those right there, they're going to sense fluid overload. Say fluid overload, or we need to lock this down. We need to lock this down right now. So they're sensing that something is not right. So the angiotensin system gets fired up. So you have low flow. The kidneys have locked down. So you have low flow to what? The loop of Henle, right? The loop of Henle. We learn all this stuff for a reason, right? So you know where the drugs work. So you know what to do if things go bad. You know, so the loop of Henle. Where does furosemide work? That's a diuretic, right? The loop of Henle, right? So if you have low flow to it, when the janitor tells you to give the furosemide, is it going to work right then? No, it's not. So we have to figure out something else what we're going to do, okay? So what do we want to do differently than the janitor would do treating this patient? Because remember, we're going to be better than the janitor, hopefully. Okay, we're going to bring our stethoscopes as a favor. It's a favor. You bring a stethoscope and you put it on the lungs. I know it's hard. Put it on the lungs. Put them on a BiPAP. So what are we doing with the BiPAP? We're putting positive pressure, right? So remember we had those alveoli filled with water? We're pushing that water out, right? We're pushing it out with the BiPAP. Just think about it. It's a fan, okay? It's a fan and it's blowing, okay? Just like if you put water on the surface and we put a fan on there, we blow it and we dry it out, right? Same thing we're doing with those alveoli. Now we're going to put a nitroglycerin drip. Why are you going to do that? So nitroglycerin decreases what? The preload and afterload. And it actually works in the lungs itself, causing vasodilation in the pulmonary circulature. So we want dilation there. So what do we want to do? Is so the fluid gets out of there. Leads to decrease in pulmonary artery pressures and pulmonary vascular resistance. And it's cheap. It's cheap like your mom, okay? It's cheap. It's cheap stuff, okay? It works well. So your hospital administrators are going to like it because it's cheap, okay? Then what happens? You open up. You open up and then you diurese. That's when you listen to the janitor and we say, thank you. This is when we're going to do this. This is when the janitor is correct, and this is what we're going to give as the IV furosemide. Then we're going to diurese because we're going to get flow to loop of Henle. Okay. So remember, this whole thing, escape, is we have sympathetic activation, and we have vasoconstriction. So the sympathetic is going to constrict. This is going to give a false signal to our kidneys and the macula densa on our kidneys. And then we're going to lock down. We're going to have our ACE angiotensin system is going to get fired up, right? So this is what's causing this guy's high blood pressures. So let's walk through all these things. This guy, what's your experience with this guy? He's hypoxic because there's water in his lungs. He's hypoxic because you gave him too much fluids, because you listened to somebody and you weren't thinking and taking care of the patient. You didn't examine him first. You gave these fluids. You hurt this guy. So now you got to fix him, right? If you hurt him, you got to fix him. Okay, so you got those fluids in there. Remember, we're not going to get gas exchange. The oxygen is not going to come in, and the CO2 is not going to get out. Real simple, right? When we explain it that way, the oxygen is not going to get in, the CO2 is not going to come out. He's in distress. His body's going, crap, if I don't fix this, I'm going to die. And he will die if you don't fix this, fix the problem that you did. And then the body is locked down and it shoots the pressures up. Now, the nitroglycerin drip, that can be controversial in the doses you give. And you can look online. There's some people that do 1,000, okay? And you can go, oh my gosh, you know. What you have to worry about is the pressures themselves, is what's the side effect of nitroglycerin. Well, first, you need to warn a patient. Say, you're going to get a bad headache from this, okay? You're going to get a headache from this. So you're going to warn them that. But your pressures can drop, and they can drop acutely enough where you need to put them on IV vasopressors. And that's going to, the janitor is not going to be happy with you, because they're going to say you didn't give the furosemide when I asked you to, and now you've taken this patient who's sick and you made him sicker. You made him where they're not breathing, and now they're not perfusing at all. So there's different things, and you can look at different systems of what people do. You can say is some people put the nitroglycerin drip at 400 and titrate it down every 2 minutes, then leaving it at 50 for about 30 minutes. After that 30 minutes, that's going to open up. We're going to reduce our preload and afterload. That's when we hit them with the diuretic. From that diuretic, then they can diurese and get the excess fluid that you unfortunately gave to them because you didn't bring your stethoscope and listen to them first. So those are things that you need to think about, is why we learn all these things. I know those classes are horrible where you have to learn the pathophysiology and the basics of it, but this all ties together, and it ties together. And this unfortunate gentleman, who's a real situation where we have harmed him because we followed blind guidance without, remember, they're guidelines. They're not maxims. They're what a recommendation is, but you are the person, the provider, that's going to make the change. All right, let's get started. Now, we looked at this diagram before, and this is the chest wall, and remember, all patients take medicine. And what we're going to do now is we're going to go from the stethoscope. Yes, it's from the 1800s with René Laennec that started this, but we're going to go to the next device, which is ultrasound. You're going to need to know ultrasound skills for working on your patients, both inpatient, outpatient, and you'll need it for boards because they're putting images on there. And we're going to show you images, and we'll show you what to look at. The reason why we have this there is the kind of point we're doing a cardiac exam, because the cardiac exam is the hardest to do as far as to get your skill level at. And we're not expecting you to know how to do an echo, and you're not going to be an echo tech, and you're not going to be a cardiologist on this, but you're getting a start. And there's going to be, we're looking at 4 different views. And this one, the first one we're going to look at is called the parasternal long. We come over here, and it's going to be second left. Now, you got to remember, if people have COPD, the heart tilts downward, pulls downward. The lungs pulls the heart downward, so it's further down. But we'll say in most people, we can get away with the second intercostal left-sided space, and we want to point that probe over to the right shoulder. That's going to be our parasternal long. Once we get the parasternal long, it's easy to get the parasternal short because you stay at that point and you rotate it and you point where your dot or wherever your main area of energy for that is going to be focused as on that right shoulder. And you're able to manipulate it to see the different valves that way. The other is going to be substernal, is right here, where your probe is facing away towards the left side of the body. And then apical is roughly about here. Here again, it's going to depend on where it is. It's much easier to do men than females because the breast tissue can get in the way. So this is where you would basically place your probes. This is a quick lesson in this to get this. This is what we're looking at right now. All right, so now this is an ultrasound image, okay? And in this image, we're gonna look at that, look at that. Okay, so what we're looking at right now, what are you seeing on this image? Okay, so on the what is this right here on the right side here? This is the left atrium. I'm sorry, right atrium. Correction. This is the left atrium. Let's say this again. Left atrium right here. Left atrium. This is the left ventricle. Right here, this hockey puck we're looking at right here, that's our mitral valve. Mitral valve. And we want it to be slapping the anterior septum right here. See? And if it doesn't slap, it's not a good ejection fraction. So this is real simple, okay? On the top of the screen, this is our aortic outlet right here. You can see a little bit right here. This is our right ventricle right here, okay? So let's look at this again, and now with our new knowledge on what we're gonna do. Oh, let's get back to it. See, look at that. Now she's placed on enoxaparin BID, and she's noted for a GI bleed. So she has a GI bleed, she has atrial fibrillation. Now she's noted for tachycardia with a heart rate of 130 and a BP of 80/40. Now the resident did what? The resident ordered 20 of metoprolol, IV. And the ICU attending saw this, panicked, and the resident was going to give it to themselves. They're going to give it to the patient themselves. And he knocked the metoprolol out of his hand. So what is going on here, first of all? Remember, cardiac output is ejection fraction times heart rate. Cardiac output is ejection fraction times heart rate. So if the heart rate's 130 and the blood pressure is already low, if by reducing this acutely, is it going to help our blood pressure? No. So your blood pressure is going to drop. Now, let's talk about when we're talking about taking care of sick patients, is the three commandments of sick patients. First, we need to defend the map. We have to perfuse. Our mean arterial pressure, we have to defend it. We also have to defend the airway. I don't care how strong you are, how good you are. If you can't breathe or get air into your lungs, you're not going to do well. And we must ventilate. The third thing, we have to ventilate, meaning we have to get the good air in and the bad air out. Good air in and bad air out. So in this scenario, is the resident's looking at the heart rate. And this is a real scenario. This was me, the resident was going to give 20 milligrams of metoprolol IV because I saw the heart rate was too much, and the attending took it out of my hands because I was looking at the heart rate. I was a resident. I wasn't thinking. I didn't know to think. Look at that heart rate of 130. I wanted to fix that, but I really wasn't thinking about the blood pressure. We have to look at the patient as a whole, as a patient as a whole.